which is solely responsible for its editorial content. Next, an in-depth look at panic disorder. To order a study guide, call 1-800-933-4AMT. The following program is made possible by an educational grant from the Upjohn Company and produced by the American Medical Association, which is solely responsible for its editorial content.
How and why it occurs are unknown, yet the fear, the terror, and the very real physical manifestations of panic disorder continue to haunt its victims. This mystery, embedded, locked in the brain, and its raging expression has long been a favorite theme for portraits. Now, science as art is gaining perspective, peeling away layers of paint, exposing the canvas of man. We are examining all aspects of the profound impact of panic disorder, its link to other psychological disturbances, and its relationship to other physical illnesses. With this understanding, a new world is opening for the individuals who've lived like prisoners within the frames of panic disorder.
When it starts, you can't stop it. There's nothing you can do to stop it. It takes over.
I wish I could explain that pain again to you. I don't think I'll ever be able to do it justice.
I felt like things would go real black, like I was actually dying, you know, right then, and I really thought I was dying. I never felt that I wasn't dying.
A panic attack is the worst thing that ever happens to people from their point of view. So if they're having repeated ones, they know they're sick, and they are. But it's not sick in the usual way. They're sick in that they have an explosive tendency to have a lot of panic attacks.
Silently stalking its target, a panic attack can strike at any time, in any place, without provocation.
I actually felt like I was having a heart attack.
What were you doing when the chest pain happened?
I was terrified. I went to the emergency room twice with this condition, and they would hook me up to their heart monitors and stuff and not find anything wrong with me. But they couldn't convince me that I wasn't having a heart attack. You know, I felt like I was.
A panic attack is a sudden outburst of nervous system activation and a subjective feeling of terror on the part of the patient.
The way these patients will present in our experience is first with cardiovascular symptoms, because the patient is feeling short of breath, or they're feeling perhaps chest pain, feeling irregular beats in their heart, something which scares them, and then they'll come in with a cardiovascular complaint. They may also have respiratory complaints, a shortness of breath, feeling of dizziness or faintness, a feeling they can't get their breath. They may have GI complaints. And a very other common symptom is ringing in their ear or a feeling of dizziness.
Some people have a sense of tunnel vision, that reality is narrowing down, that stairs, if they're standing at the top of the stairs, that stairs look tremendously high. Sometimes a person can be sitting in a room and looking at someone they know very well and say, "You're my mother, I know it, but I don't really believe it." Or they somehow feel as if they're floating outside of their body. They actually feel like they're going to get out of their body.
The syndrome really then is a repeated panic attacks, often then complicated by avoiding, and maybe completely avoiding. So 5%, in the worst case, 5% actually don't leave the home, maybe for many, many years.
Panic disorder may be familial, invading the lives of young children, teenagers, and adults. Most often it's seen in 25 to 35-year-old persons. But generally, the onset of symptoms is seen among individuals ranging from their early 20s to their mid-40s. And women seek treatment far more frequently than men. It's not uncommon for people to suffer the devastation of panic attacks for years and years and years.
Some people have them every day, some people have them less frequently. So the acute panic attack is the first part. The second part is something that we call anticipatory anxiety, and that's a fear of when is the next attack going to come. The third part is what we call phobic avoidance. The person with panic attacks starts to become afraid of getting one of these attacks in a situation where they can't get help. where they might be trapped or can't get out right away or can't get to a hospital right away. In the worst case scenario, the person becomes afraid to go anywhere unless they're accompanied by somebody they trust, and that's what we call agoraphobia.
While the etiology of panic disorder is unclear, there are two schools of thought on its origin: biological and psychological. Biological philosophy suggests a panic attack may be associated with a triggering or hyperactivity of the brain's fight or flight mechanism.
There are some studies, some primate studies, that suggest that it involves certain circuits in the brain. Now, this is controversial, but the locus ceruleus, the parahippocampal area, and some central gray areas that may be overly active in panic disorder patients. They're probably the circuits involved in anxiety and severe anxiety. But the idea appears that with certain of the positron emission tomography PET scan data, that the temporal lobes are involved in any kind of anxiety, but maybe the sort of evaluation system of the brain of whether this is a tiger or a kitty cat who's come into the room, that system may be involving the parahippocampal areas and perhaps the locus ceruleus, that system overreacts to incoming anxiety stimuli in people who have panic disorder.
Others have a more psychological view of panic. Some see panic attacks as a phobic response to somatic symptoms. They feel chest pain, they say, uh-oh, I'm going to get a heart attack. They get scared because they might be getting a heart attack. That fright increases palpitations and chest pain. They begin a vicious cycle, which goes quickly into a panic attack.
In addition to that, there's evidence that in the month or two before somebody gets their first panic attack, there's an increased amount of life trauma, psychological stress, and things like that. So we think it's a convergence of a genetic predisposition manifested by autonomic nervous system hyperactivity and psychological events and life events that actually come together to produce the panic attack.
Panic disorder is nearly invisible to the outside observer. Even in the midst of an attack, it's only the victim who can truly see and feel the escalating terror claiming them as a prisoner. The physical result is internally all too vivid.
I feel like I'm going to pass out.
Anything else that you're feeling?
My legs are real weak. My arms are real weak.
How about the sense of feeling like you're going to die?
I'm not feeling that, thank you.
You're not feeling that, thank you?
No, I don't think this is a very bad one.
While duration is generally short, 10 to 20 minutes, the effects linger.
I never really realized it was only 10 minutes because I always thought it was all night long. I will be laying there and I will feel this pressure up on my chest. And next thing I know, I will get like cold, just chill where I can't get warm, and I put covers on me and lots of covers on me, and I still can't get warm inside. My palms will start sweating. I feel like I'm going to pass out. Everything seems to really turn black on me.
Estimates are that 2 to 5% of the population live with this condition. But panic disorder often has company. Major depression, alcoholism, or drug abuse frequently exist concurrently.
The suicide rate in this population is actually higher than average. People tend to have serious restrictions. They have travel restrictions, they have comorbidity with depression and with some GI problems. It can be very pervasive in their lives. They have relationship problems.
Routinely, panic disorder mimics other conditions.
Panic disorder can be mistaken for any kind of cardiac problem like ischemic heart disease. It can be mistaken for abdominal problems like inflammatory bowel disease or irritable bowel syndrome. It can be mistaken for migraine, other kinds of headaches, neurological disorders if there's dizziness and lightheadedness, and so on. It's really quite extensive. 10 different organ systems can be the site of the symptoms.
Consequently, proper diagnosis is one of the most puzzling, frustrating aspects of panic disorder for primary care specialists.
Chest pain is the 8th most common presentation in primary care medicine. It's also true that many patients who come into primary care physicians don't have heart disease. And many of these patients believe they do, and their physicians have to think that they might, particularly if the chest pain is accompanied by shortness of breath, comes out of the blue, and maybe the chest pain is characterized by some kind of pressure, and it might be exertional, and the person may have some risk factors. The physician has to do a further evaluation.
A clutching, gripping feeling in the chest is rightfully cause for anxiety. And believing that they're in the midst of a coronary event, many people do exactly what's expected. They rush for help to their family physician, to their local emergency department. The outcome, though, is generally not what the patient expects. We'll explain in a moment.
You can't hear people talking, and they sound far away, and you know something's going to happen, at which point your heart begins to pound, and you feel like someone has a hand over your mouth, and you can't breathe. Your legs get very wobbly, and you have to get out of where you are in order to stop the feeling.
The physical symptoms of panic disorder emulate those of cardiovascular disease. This confuses the primary care physician and patient alike.
They often get a large somatic workup, almost always resulting in either very trivial findings or nothing. Prior to recent history, we didn't recognize that the syndrome of repeated severe panic was a syndrome that explained all these somatic symptoms and all these anxiety symptoms. They were told, and to some extent still are told, that what's wrong with you is you're just anxious. And for the patient, that is extraordinarily unsatisfying, because they're not just anxious. Their friends are just anxious. Everybody's just anxious. They're having from 1 to 6 panic attacks a week or to 30 a day. And they're horrible every time they have one of those. It's like the worst thing that ever happened to any human being.
I found myself going to a lot of doctors, and I don't consider myself a hypochondriac.
Connie SPANN, a former television personality, is married to a prominent cardiologist. Suffering from panic disorder for 7 years now, neither she nor her husband knew what was wrong with her.
I was getting terrible headaches. I went to an ear, nose, and throat doctor because I thought I was having an inner ear problem. My husband had to take me into the hospital because I was getting extra heartbeats, and I thought I was having a heart attack. And they even put me on heart medicine. I went to a chiropractor. And I thought I had a brain tumor. I got a CAT scan. And they never could find anything wrong with me, and I knew that there was something wrong with me.
Searching for answers, panic disorder patients demand services. Before they are accurately diagnosed, patients average 10 medical contacts, and often they go so far as to have cardiac catheterization to learn the nature of their ailment. Of the 700,000 performed yearly, approximately 200,000 have normal coronaries. Of those, 1/3, or 70,000, fit the profile for panic disorder. Cost estimates range in the area of $210 million for this test alone.
Unfortunately, what often happens is that the person gets a normal catheterization, and the cardiologist says, I have good news for you, your heart's normal. Well, that is good news, but it doesn't explain to the patient why they have these panic attacks, and there has to be further referral then to somebody who can take care of that. Otherwise, although the person's reassured their heart's okay, they're still suffering from this very serious illness.
Studies have shown that panic disorder patients are at greater risk for coronary heart disease than are controls, yet they may have no actual manifestations of the disease.
We don't yet know what the reason is that patients with panic disorder have a higher than expected mortality from cardiovascular illness, but physicians need to be aware of that phenomenon and to make sure they're assessing the risk factors very carefully.
So it really depends on what their symptoms are, but since they have 4 or more symptoms, they're likely to get an extensive workup, and it's probably $200 to $500 per visit. So that's $2,000 to $5,000 before they're diagnosed.
As part of standard practice to reach an accurate diagnosis, a complete cholesterol and lipid profile should be performed. And certain procedures like treadmill exercise tests may give greater support to the absence of CHD, but the patient needs proper reassurance.
It's much better to say specifically your heart rate is, you're watching the person on the treadmill, your heart rate is at this level, your blood pressure is at this level, you're at this workload, and then to begin to allow the person to learn about what's happening to them as that test is going on. When you do that, the treadmill tends to be a lot more useful.
We say then that a patient should get a physical examination, electrocardiogram, and routine blood and thyroid function tests before you make the diagnosis of panic disorder, all of which can be done in a couple of hours.
A lot of physicians didn't learn about it in their training because it's a diagnosis of the 80s, really. In addition, many physicians are focused primarily toward the biological, and they don't include in their thinking mental disorders that can present physically.
Among specialists, there is speculation that panic disorder is causally related to mitral valve prolapse. MVP, based on echocardiogram data, is the most frequently diagnosed cardiac valvular abnormality. The presence of MVP, however, does not indicate a greater tendency towards panic disorder. But among patients reporting panic attacks, there is a higher prevalence of MVP than among normals.
We do not think, and this is an important clinical point, that the prolapse is causing the panic attack. In fact, it may even be the other way around, because our studies have shown that in those patients with panic disorder who do have mitral valve prolapse, that it's not the congenital form of mitral valve prolapse. The valve actually looks normal when you look at the valve. It just flips up into the left atrium when the heart contracts. And we have some evidence, although it's preliminary, we haven't proven this yet, that if you treat somebody's panic disorder, after they've gone for about 6 months of having no panic attacks, that the prolapse goes away.
At the University of Missouri in Columbia, the research of Dr. Bernard Beitman focuses on the incidence of panic disorder among former cardiac patients. These are patients who have no other symptomatology other than reoccurring chest pain.
Because the physicians are not aware of panic or are not familiar with making the diagnosis, patients with MVP and panic symptoms are put on beta blockers.
Beta blockers may relieve some symptoms, but they will not help the real problem, the feelings of rage and fear that well up inside the person with panic disorder. Researchers at Columbia University in New York use lactate infusion, inducing panic attacks, to study the relationship of cardiovascular physiology and pathology.
Looking at various markers of autonomic nervous system hyperactivity. One way we do that, for example, is to challenge the respiratory system with very small amounts of carbon dioxide and look at the reflexive increase in ventilation, which seems to be more robust in panic disorder patients than normal controls.
In the meantime, panic disorder patients continue to appear in the offices of primary care physicians and in emergency departments.
If you can get a history that the chest pain is episodic, lasts for 5 or 10 minutes, is accompanied with anxiety and other systems and other organ systems, it should raise your index of suspicion for panic disorder.
For the true diagnosis, all they need is 3 more symptoms, the chest pain plus 3 others, and a frequency of 4 in the past 4 weeks, and they qualify for the diagnosis.
Following diagnosis and referral, when appropriate, the next question is how to effectively treat these patients.
We can say with confidence that although we don't know for sure what causes panic disorder, and we can't really cure a condition unless we know the cause of it, that we can make people substantially better in about 90% of cases now.
A handheld computer may provide some insight into the precursors of panic attacks and how best to treat them. Subjects record their sensations hourly, up to 17 times a day, as well as when a panic attack occurs. The results are being analyzed as part of a study at Stanford Medical Center in California.
Well, we hope to find a pattern that involves what people are thinking and how they feel, possibly what they're doing, that will let us predict when they're going to have a panic attack.
By assessing the nature and severity of these events, physicians may have better tools to repair the psyche of their patients. Current treatment therapies involve psychotherapy alone or in combination with medications. There are 2 behavioral approaches, either cognitive behavioral or...
Wolfgang, what are you doing? No, I don't...
classifications of agents used to treat panic disorder: polycyclic antidepressants, high-potency benzodiazepines, and monoamine oxidase inhibitors. All of them reduce the nature and severity of panic attacks, but they must be tailored to the individual patient.
What you find with the tricyclics is that about a quarter of patients have a very strong reaction to the medication, characterized by some symptoms that may seem very much like anxiety. So the patient, say, begins to take imipramine, suddenly they feel a sense of hyper alertness, they may feel more anxious, they may feel jived up, they experience sweating of their palms, sometimes flushing. They don't want anything to do with the medication because they've been suffering from symptoms, and here are more symptoms.
Benzodiazepines have a shorter half-life and are rapidly effective, but for some patients they may initially be sedating. They are contraindicated for substance abusers.
If a patient is on a benzodiazepine for more than 4 months, taper must go relatively slowly, at least over a 4 to 6 week period, preferably over an 8-week period, depending on how high the dose is. So the message here is that for patients with benzodiazepine treatment in panic, physicians must be prepared to help them withdraw.
The MAO inhibitors, these medications are probably underutilized. In samples that we've done in the community, they tend to be fairly rarely prescribed. One reason being that they interact with various substances found in common food, so that physicians tend to be reluctant to use them.
Treatment should take 3 to 6 months, and patient compliance tends to be very high because these medications bring relief to the patient's symptomatology. In long-term therapy, over 4 months, the physician should periodically reassess the effectiveness of these medications.
And one of the most gratifying things is that after treatment, they often, I mean quite often, send us thank you notes and use the phrase that, "Thank you, your treatment actually gave me my life back, because I now feel like I can live a normal life again. You know, thank you for giving me the freedom to live normally again," and they do.
The preceding program was made possible by an educational grant from the Upjohn Company and produced by the American Medical Association, which is solely responsible for its editorial content.